the idea of this came from Mike Waxman and Mike Lyons and Phil and Alyssa. Sorry, it's early. And so I think like we'll try to go through the points quickly. Thanks for coming, and have some discussion around some of these ideas. So this is just a disclosure slide. We had through SAEM, Alyssa and Dr. Perkins and I had a grant to do some educational initiatives for SAEM around monoclonals, but also on vaccination and treatment. And there's actually some stuff up there we'll show you on the SAEM website. And Dr. Michelle and Waxman had no conflicts. So the Untitled group, some of you guys may have participated in this, maybe you haven't. So this is a group of people who came together about 20 years ago thinking about public health initiatives and the emergency department. So this is obviously became a big issue, even though there's only 5 of us in the audience, like around a pandemic. I was like, what's our role in the emergency department associated with public health problems? Like, do we actually have a role, don't we? And the group initially came together around HIV testing, and there's actually a ton of work done in that space to try to improve clinical care for people with that disease. And at that time, when I started, people were like dying from AIDS. Right now, a lot of people aren't dying from AIDS, but the impact of testing had a significant impact on getting people into care. And there's probably issues around COVID and other pandemics that the ED has a value in. So this group, it's small, but we're nimble, right? We continue to kind of do work in this space around the intersection between particularly infectious diseases and public health. So Mike Lyons, I think, and Mike Waxman, and I'm kind of the stand-in guy for this because Mike is working a shift, but started asking like very early on in the pandemic, like everybody got involved in different things. And we said, what's our role like in terms of like addressing some of the pandemic issues? And obviously from a clinical standpoint, it's managing emergencies, but it's also like advancing the science for diagnosing and managing patients, and also trying to support patient and population health. So there's issues around diagnosis, treatment, prevention, public health, and a few very industrious people came together. And there's work out there, but it's kind of small of like, what can we do as the emergency medicine community and the issue of vaccines. And we were talking about this yesterday. It's like, how did emergency medicine do, like as a community, for the whole pandemic in terms of public health response? And we scored ourselves, you can see like after, but if you think about it, and from a big picture of like, what did emergency medicine do, and what are we doing now in terms of the pandemic? It's an interesting question, like from the big picture of the health system. So one of our wins as this M-Type group was getting Anthony Fauci to come give a talk for SAEM, and he chose it, like we weren't sure what, at that particular moment he was going to speak about, but he ended up coincidentally speaking about vaccines. Like that was the whole focus of that discussion. And there was some, important learnings around that, but also sort of introducing a lot of what the gaps are, and thinking about future pandemics. And all of us are involved in different ways in infectious disease issues with public health department, CDC, and other organizations. One of the things we did on the right there, that's the thing that we did with Glaxo and SAEM, is putting up information on SAEM website about, how do you break down barriers with talking to patients, both for treatment and for public health issues like vaccines. So here are the folks who are going to speak, Alyssa Perkins, who's an associate professor at Boston. Are you a professor now?
We were just talking about that.
You should be a professor.
I'll come to you for my letter.
So this is like kind of different perspectives on this issue, and these guys were saying, well, I was saying you guys are the tip of the spear, and Mike said it's a really short spear, but it is what it is. And Phil Muscella, who's relatively recent grad, but an old soul from Prisma Health, University of South Carolina, and Mike Waxman, who's a long-term colleague at Albany Medical College. I think that's it. I guess the other point when we were thinking about framework in this discussion is, each of these guys came at this from a different angle. Alyssa's like in Boston City's like an urban ED, very public health oriented hospital, and she said like I'm going to figure out how to do this. And Phil's in South Carolina. I don't know that I've never been to that system, but it's more of a community based place, and he's also like relatively like new in terms of his practice, but he did it too. And Mike Waxman is more into sort of discussing some of the issues. So these are the two different perspectives. One's city, one's urban community, and Mike's more thinking about the issues of how do you address issues like vaccine hesitancy and uptake.
So I'm going to get going and kind of start with the case for the emergency department and why we're even thinking about vaccinating against COVID-19 in the emergency department. And when I first started talking about this in January of 2021, I got the very common question of like, why the emergency department? We have so many burdens on us already. We're all overworked. We're overwhelmed with all these COVID patients. Like, can't the PCP, can't the vaccine clinics, can't they do this routine healthcare maintenance? Why do we have to do this? But it's really important, and this group has been very good at thinking about it this way, but we are really, in the emergency department, at a very unique position in our healthcare system. We're at the interface of the inpatient setting, the outpatient setting, and the community around us. We take care of the vulnerable patients without any regard for their ability to pay. We see more patients that are minorities, that don't speak English. We see patients that are disproportionately housing insecure, they're job insecure. They're more likely to have mental health problems, substance use disorders. Like the patients that we take care of also don't interact with the healthcare system. Oops, sorry, I'm totally pressing the wrong buttons here. The patients that we interact with also don't interact with the healthcare system around them, right? They are very unlikely to access routine medical care. And this became especially true when the pandemic hit, and we saw medical centers and outpatient care was closing all around us, or if they weren't closing, they were moving to telehealth. But at the same time, the emergency department stayed open 24/7, taking care of our patients. So we were open and we were seeing these patients that are not otherwise seen. And essentially, in the emergency department, we have access to patients that are particularly vulnerable from suffering severe effects from COVID-19. Those who might not have other opportunities to interact with their healthcare providers about vaccinations, and those who are just less likely to access vaccine opportunities. So it just makes sense for us to think about vaccinating these patients when we actually have them in front of us. There's been increasing recognition over the last decade, led by many of the people on this panel here, that in order for EDs to really be effective in taking care of our patients and improving their health, we need to do more than just care for the isolated issue that's in front of them, because that one issue that brought the patient to the ED is often the culmination of lots of life events, and unless we work on these outside factors, we won't truly improve our patients' health. So we've seen more and more efforts nationwide to truly engage in preventative care and public health initiatives in the emergency department. Many EDs now have programs in place, especially thanks to a lot of Dr. Rothman's work, where we screen patients for hepatitis C or HIV, or we start patients in medication-assisted therapy for substance use disorder. So it's becoming more and more acknowledged in the sphere of emergency medicine that we should be engaging in public health initiatives in the emergency department. So hopefully I've made the case to you, but it's really important before we get going on initiating a program that we identify and engage the stakeholders before the program gets underway, because that's the most likely way to ensure buy-in, rather than like, oh, by the way, I've started this program, Don't you love it? So obviously, emergency department physician leadership is really an important starting point because they need to ensure that the rest of your physician population is on board with the program. I'm pretty fortunate because both our emergency physician population overall, as well as our prior chair and our current chair, are very engaged in the public health mission of the emergency department. So they were immediately on board, and the question turned very quickly from, should we be doing this, to, well, of course we should be doing this, how can we do this? And that was an important inflection point for us, is that conversation shifted really quickly. Obviously, emergency department nursing is a critical player here because if they are not on board, it's not happening. We are depending on them for a lot of the actual work of the work. They're the ones who are administering the vaccine. So it's really important to get them on board early and make sure that they are comfortable with the flow that we've decided on. Engagement of the pharmacy team is going to be really, really essential because they have to manage the storage and the mixing of the vaccine. The question came up early on as well, is this going to be obtained from the hospital central pharmacy, or are we going to store it in the emergency department itself? And that became a question with the mRNA vaccines and the cold chain requirement. It became pretty much impossible for us to think about storing the vaccine if we were going to use mRNA vaccines in the emergency department pharmacy. So we were looking, if we were using mRNA vaccines, at getting it from the central pharmacy. And then the other question was, anticipated volume, how are they going to work that? So pharmacy was a really crucial player early on. We actually heard the message from the Department of Public Health, who we also engaged early on, that they were really concerned about wastage. So back when we started talking about this was January of 2021, and vaccines were not at all available. They were a very supply-constrained resource. And they were very concerned that we would be wasting vaccines, and they wanted to drill down where would we be getting this vaccine from. The way it worked in Massachusetts was the Department of Public Health gave the vaccine supply to individual hospitals to administer. And that became a question because I was thinking that we shouldn't, if we were initiating this program in the emergency department to take care of vulnerable patients, we shouldn't have to cut into our hospital supply, which was already limited. We should get a supply directly from the DPH earmarked for the hospital. And I was able to make some headway with the commissioner of the Department of Public Health in sort of getting her on board with this plan, although ultimately I never got her all the way there, and we were stuck kind of taking some of our hospital supply. But she was on board enough that they did put out a memo to the entire state of Massachusetts saying that emergency departments should be giving COVID vaccines and they should figure out a workflow in order to give COVID vaccines. Let's see what else. Obviously, hospital leadership needs to be involved. We're very lucky again in our institution that we're Boston City. Like, there is a public health mission baked into our hospital. So they were very easy to convince, but they actually had a number of different concerns that I had not anticipated. The first was when we started discussing this, as I said, it was still a very constrained supply, and they were really worried that we would become a vaccine clinic, that people would be coming to the emergency department only for the purpose of getting a vaccine. And this really mirrored conversations that I'd heard when we started HIV testing, when they were very concerned that people would come to the ED only to get an HIV test. And I was able to reassure them that, similarly to that fear that we'd had early on, we never actually saw it come into play. And I thought, given who our patients were, it was unlikely that they would be coming to the ED just to get a vaccine. That said, I was not able to convince them, and we chose to wait until the supply was less constrained before we started offering it in the emergency department. The other concern that hospital leadership brought up that I really hadn't thought about at all was the fact that if patients suffered from just routine vaccine side effects, especially a fever, it would really confound their care if they were admitted and potentially lead to elongated hospital stays. And they were not very comfortable with that plan because they didn't want to increase our length of stay for fever. So we made the decision very early on that we would only be giving it to discharged patients for exactly that reason. The final stakeholder that is really important to get involved is the community from which our patients come. This is particularly important to address vaccine hesitancy. Having some respected community partners, ideally those who look like our patients with regard to race, ethnicity, and language, that are vocal in their vaccine advocacy, is going to be really, really important. We tried to have them embedded in the ED to actually answer questions and encourage patient acceptance, and we were unable to actually implement that because we still had COVID restrictions and we couldn't get volunteers to get past the hospital system into the ED, but we did try, and I think it would have been really awesome if we'd been able to accomplish that. We had people from various community-based organizations who were willing. So choosing the right vaccine is the next question that comes up. And for us, when we first rolled out our program in early 2021, it was very clearly the Johnson & Johnson adeno-vector vaccine. The storage requirements were the easiest because it didn't have the cold chain. At the time, it didn't require us to schedule a second follow-up appointment for a second dose. And then we didn't have to worry about as many wasted doses in the multi-use vials. One thing that we feared early on that I guess is kind of coming up as relevant again today is that how we were going to manage the concern that we were giving these socioeconomically vulnerable patients a vaccine that was at the time perceived to be inferior. But what we were able to kind of explain to hospital leadership is that we had learned that even if it might be a little bit inferior as far as protecting against cases, it was still quite effective in preventing severe disease and death. And so it was a little bit we were able to make that case, and as it turned out, this was not on the minds of our patients at all. I really hadn't seen a single concern from a patient about this. Actually, a lot of patients were more in favor of it because they felt that the technology was more familiar. Not that they knew about technology, but that's what the newspapers told them, is it's the same technology that we've used before as opposed to the mRNA vaccines that are new technology. That said, we still felt that choice was really crucial, and so for patients that did not want to get the Johnson & Johnson vaccine, we basically explained to them that they could still get the mRNA vaccine. We had a vaccine clinic that had walk-in hours that was open by the time we started doing this in the emergency department, so they still had a choice. And I guess the last thing to note is that this is really going to change over time. Just last week, the FDA changed their recommendations. I don't know how many of you saw it, but they now have basically stopped recommending the Johnson & Johnson vaccine almost completely, except for patients who have some contraindication, like absolute contraindication to the mRNA vaccines, or who just otherwise would not get vaccinated. So this decision as to which is the right vaccine is going to change over time. So vaccine administration protocols are really important, and it's really helpful if you can have a workflow that is diagrammed out before go live so that all the team members are aware of all the processes, because just because I'm super familiar with it doesn't mean that anybody else is. So we developed these handouts to give to all providers, both nursing side, pharmacy side, and physician clinician side before we went live. One of the first things that we did was had our IT team move the COVID vaccine status to the storyboard. So as soon as you opened up the patient's chart in the EMR, you could see what their vaccine status was. It pulled in from the state's vaccine registry. So it was fairly accurate. I would say, it doesn't always get entered into the vaccine registry. Sometimes there's a little bit of a delay before it gets pulled into the registry. And then any patient who didn't get vaccinated in Massachusetts, we obviously wouldn't have that record. But at least it gave us a starting point as to which patients we don't need to approach at all and which patients we should think about approaching. The next thing we had to do is make sure that there was very little likelihood that they were going to be admitted based on our hospital's concerns. But once we made the determination that they were unlikely to be admitted, either the physician or the nurse could start to engage in a conversation with them about whether they'd be interested in getting vaccinated. We also had our pharmacy students who were very interested in this project, thanks to our amazing public health pharmacist who is as committed to public health as those of us in this room are. And she would have her students scroll the board looking for who might be eligible for vaccination. So we developed these hospital-wide education materials that we could give to patients, and then we'd have a discussion with the patient about whether or not they were interested in getting the vaccine. We kind of opened the door to talk about vaccine hesitancy, particularly because our patients are, primarily racial minorities who are much less likely to be interested in getting a vaccine. And we kind of operated under the belief that even if we couldn't convince a patient to get vaccinated that day, having that conversation and opening that door would be much more likely to have the next provider at least be able to get them to yes. So if the patient agrees to get vaccinated, we developed a one-click EMR order where it basically orders that Johnson & Johnson vaccine with one step. That EMR order does a look back in Epic just to make sure that the patient is eligible, i.e. there's not an admission order, that they were age over 18 because that was all that was EUA approved at the time, that they didn't have a positive COVID test in the last 10 days, that they hadn't received monoclonals in the last 90 days, all of those things. We automated that to make sure that the patient was actually eligible. that point, the pharmacist mixes the vaccine, fills out the vaccine card with the lot number and the expiration date so that they have their, vaccine passport. They give the vaccine to the nurse administers the vaccine, and then the patient is observed for 15 minutes, and other than that, the rest of their ED visit just takes place the way it normally does. So we first went live with this program on April 13th, 2021 at 7 o'clock a.m. We paused our program April 13th, 2021 at 8:22 a.m., less than an hour and a half after we went live, because that was the day that the FDA paused the use of the J&J vaccine due to concerns for TTS. So it was a total bummer of a day, because that just happened to be the day that we were able to start. And it was incredibly disappointing. We actually had 3 patients that were ordered for the vaccination on that first day, and not a single one of them got the vaccine because of the pause. It was a lot of conversations between myself and the CMO and the head of pharmacy, because it was just so disappointing, but we obviously couldn't do it. So due to the changes that we wanted to make in our discussions of the vaccine, we were not actually able to go live again until May 13th. And at that point, we had additional discussions with women who were under age 50 years about the risks of TTS. So it's really important once you implement a new project that you kind of reassess and reform it. And so early on, as we realized with HIV testing, it's actually incredibly challenging to have Native clinicians be involved in these public health missions. So because our hospital was so engaged in this program, within a couple weeks of our rolling it out, they were able to provide us with a full-time equivalent resource nurse from the hospital whose sole purpose in the emergency department was to vaccinate patients. He would basically scroll the board, look for patients who might be eligible for COVID-19 vaccines, and then have these conversations, engage their hesitancy, talk with them about questions, and then administer the vaccine. He got his supply of vaccine from the hospital pharmacy, and he was able to carry with him both the mRNA vaccines and the Johnson & Johnson, so he was able to do it all himself. He didn't even require the pharmacist, he didn't require anything, because he had the vaccines mixed and was able to give them. So it was a huge boon. We were able to quickly really increase the number of patients that we were able to vaccinate. He was also able to schedule second appointments for the mRNA vaccine, so it was really quite successful. The other thing that was really, really amazing that he was able to do was he was able to vaccinate our staff who didn't have an ED visit at the time, but back at that time, we were just starting our booster requirement. We'd already all been required to get vaccinated, but we implemented a booster requirement. So tons of our staff needed to get boosted and were, a little bit lazier about getting the booster than they were about getting the initial vaccine. So having the ability to get vaccinated in the ED was super important. And then, as I'd mentioned, vaccines became less scarce during the course of this program. And so the other reassessment that we made was we decided to actually offer the mRNA vaccines even from the pharmacist itself, even if the numbers were decreasing, with the acknowledgement that we would be potentially having more waste. We'd be, these 10 vaccine vials, we might only be using one of them, but in line with what the CDC and FDA were recommending, vaccines were no longer a constrained resource in the United States at least, and it was worth it to get an additional shot in somebody's arm, even if it meant that we were not going to use all of them. And I'm going to just put on my research hat right now and note that any program that implements a vaccination program needs to make sure that they're really assessing it, at the minimum for QI purposes, but also to inform the rest of the community about the importance of the role that the emergency department can play in vaccinating our communities and public health endeavors in general. There should be efforts to document the number of patients approached, those excluded, those that agreed, the numbers that actually received the vaccine after agreeing. Numbers of wasted doses should be captured, as well as reasons that people declined and reasons when people were accepted the vaccine that they didn't actually get it. So over the course of our program, in the last year, we've actually managed to vaccinate over 500 patients. We have a poster that we're presenting on this later this afternoon, or later this morning, I guess, if anybody's interested. But most of the patients that we vaccinated were younger. They're people of color. They are people who initially did not want to get vaccinated or never got around to getting vaccinated. There are some that we've approached that have basically said they just don't feel they need it, or they still don't want to do it until more time had passed. And we're sort of thinking about ways to continue to talk with those patients and engage them. And I think Dr. Waxman will have a little bit more about vaccine hesitancy as we go on. But that's the summary of our program. So I'm going to let Dr. Michelle go.
Alrighty, so thank you so much. Philip, I'm going to show the other side of that coin, which is a little bit more of a community ED sort of response. And when I say community ED, what I'm talking about is right here in South Carolina. There is a South Carolina besides North Carolina, so there's one right here. And I primarily work at this little hospital right here. It's not quite that big. This star kind of represents how big it is. But basically, it's Greenville Memorial Hospital, part of Prisma Health. We used to be a smaller regional health system. Now we're a bigger regional health system. So there's about 6 hospitals that cover the, wrong picture. Cover the upstate region of South Carolina. And then we merged with Richland Hospital System now, which covers most of Columbia. So we are a hospital system that covers about that much of the state, kind of about midway down to about Charleston. So we are the largest player in our state. Market share is probably a little bit more than 60%. They'll report 60%, so we don't have federal regulators, but that's just it. So we cover this whole area. We are not an academic institution despite having a lot of residency programs. Our medical school is the University of South Carolina School of Medicine, Greenville. So just to put that in perspective, so there is the University of South Carolina School of Medicine down here, and then we have our own, but it's the University of South Carolina School of Medicine, Greenville. Okay? So just to kind of preface why this is sort of important and why it's a different side of that coin. Our emergency department is actually fairly new. It only became part of the hospital system about 7 years ago. And so there is a little bit of a focus in the sense that they're pulling people in to try to have some sort of an academic footprint because we have a residency program, but up to that point it was not there. So I'm not trying to be a shill, just trying to tell you community shop, big market share. As far as public health importance, the only reason they're interested in public health is out of a self-preservation standpoint because they don't want to be overwhelmed with otherwise patients. So in response to that, what we did as part of our health system was trying to work with our public health department, which has a number of issues associated with it. Because we otherwise work in the South, depending on your community and your racial and ethnic community that you live in, you may or may not have a certain level of distrust with public health. We are close enough to Tuskegee that there are lots of people that do not trust the health department. Also, our health department, as it stands, is not the most well-funded. I'm not going to lie about that. We don't have a ton of government money that goes to our public health department. So their ability to help support vaccine clinics directly through the health department is very, very limited. So as a response to that, our hospital system kind of picked up the line here and actually set up a vaccine clinic. The reason why I bring this up and not talking about the emergency department is because the only reason I was allowed to try to push vaccines in the emergency department is because this was going to close. So at the beginning of it, I said, hey, we need to do vaccines in the emergency department, and I didn't get a heck no. I got a lot of expletives no. And it was from everything from storage, waste, traffic patterns. I'm like, are you kidding me? The traffic patterns are already messed up. Are you really telling me that we can't do vaccines in the emergency department because you're worried about traffic? Anyway, that being said, we did set up the vaccine clinic, which is about 400 yards away from the hospital across sort of a busy road, but that's okay. We took over this old Kmart here, which has a really fun game as Guess the Stain, as you kind of walk around the floor there. But basically, it was a really well-funded area. Our SAEM nurse coordinator was actually one of the main driving factors about setting up this clinic. We had multiple buy-in from across the hospital system to try to set this up, to try to put as many needles in arms as possible. We set this up to do about 5,000 vaccines a day. I volunteered during the first week there on day 2, took care of 2 patients that had vaccine reactions, one that got admitted, was putting needles in arms. I did about 40 vaccines on my first day. And so it was a really kind of all hands on deck kind of thing, trying to revamp this. And like I said, the only reason I bring this up is because it was only when this was set to close that then they said, oh yes, we can use the emergency department to do vaccines. So this is our emergency department, and we're all set to close. So about 2 months before it closed, they finally said, you know what, Phil? You've been banging away at this for a long time. Yes, you can start to plan to do vaccines in the emergency department. Pharmacy finally let me have access to this, gold resource of vaccines to be able to do into the emergency department. So, what's the program that we set up here? So, I'm having to shoehorn this into a community hospital that was already really against this. Okay, so what I talk about here is I'm talking about how to try to shoehorn this in a place that doesn't really want it. Okay? And so what we tried to do is set up ways to get around vaccine hesitancy, ways to get around distribution, ways to get around waste, ways to get around all these things in a community setting. Our emergency department here in Greenville Memorial is fairly busy. It's about 106,000 adult patients a year. We're set to be up about 10%, I think, this year over our normal average. And so it is a fairly busy place, about 60 beds, and we always have, anywhere between 18 to 20 bed holds, just like anywhere else. So what did we do? So, in trying to shoehorn this in here, basically I added into the triage to try to get around vaccine hesitancy. So I'm not sure this shows up really well, but to try to get around vaccine hesitancy, I didn't want to waste time with patients that said, I don't want the vaccine, don't talk to me about it, whatever. I'd been yelled at too many times about saying, don't tell me about the vaccine, it's poison, it's from the CDC, and da-da-da-da-da. So I didn't really want to get into that. So what we did is we asked one simple question, was basically, have you received a COVID-19 vaccine? And then we asked them, did you receive it, and would you be willing, if we were able to give you a vaccine today, to get the vaccine, right? And so basically what showed up on our track board then is basically, yes, the patients received the vaccine, and then it would ask, did they get 2 doses, booster, everything else like that. Were they not vaccinated, right, and willing to be vaccinated today, not vaccinated, not willing to be vaccinated today, or unknown or unable to ask. So that way the nurses have a way to kind of exit out and if the patient's obtunded or doesn't want to answer and everything else like that. So basically,
the nurse doesn't want to.
Yeah, that too. But basically then here is the track board. And this is our standard ED track board. And way over here on the side, it was kind of there. And I also had to make this optional for the ED physicians to add to their track board. It wasn't made mandatory. Just put that out there. This is how to shoehorn things here. And you could add it in over here. And so there you have no, not willing, unable to ask, willing, and then been vaccinated. So you're looking for the W. Go for the win. Okay? And the way that we added this in there on top of that is that we did have some of our inpatient colleagues actually that were given vaccines. It was variable about who was doing it and things like that. It wasn't sort of standardized or protocolized. But what would happen then is sometimes we would order a vaccine and then they would have like a scramble to try to find inpatients that would want to get it or the ED that would want to get it and things like that. So it would be a scramble when it was first started. This was in June. And so we decided to only go after our EUA supplies, okay, of Pfizer is what we had. And the reason why we used that is because that was the biggest stockpile of vaccine that we had that we felt was disposable. Again, ED is allowed to get the disposable resource that's on the EUA to try to make this work. We had the luxury, however, because originally when I proposed this, we were saying, yeah, we were going to do adenoviral, but while in discussions, they're like, heck no, all that information came out right when our discussion started, so we didn't have to worry about shutting it down. They just said, no, we're not going to do it. We don't want some bad press to come out. Again, because it's a community shop. You have one bad article about it, they're going to forget it. You're fired. So basically, they wanted us to make sure that we didn't have anything that would be otherwise perceived as something negative. So anyway, this is the way we set it up, was actually go for the W. And at that point, if there was vaccine that was available, pharmacy would kind of come down and say, hey, do you have anybody that would want the vaccine, have anybody that wanted to get the vaccine, and kind of put needles in arm, whether that was actually started from us cracking a vial or inpatient side was cracking a vial. So how did we do? Our first month, when we rolled this out in June, we did about 45. Woohoo! It's amazing, right? By October, we had done 15, and in November, we did none. And we still have done pretty much none, maybe 1 or 2 here and there. And that's partially because overall our disease burden has sort of otherwise come down, thankfully, into our area. And it's kind of lost a little bit of assessment and retouch because there wasn't a lot of education that I put out about this because everybody was so COVID numb at this point. I wanted to make sure that I gave a way for those physicians, those nurses, everybody that was super passionate to have a way to have access to be able to deliver this, but not force it down everybody's throat. One is because I don't want to lose the ability to reach out to my physicians and colleagues for the next pandemic. So what I'm really trying to set up here is pathways to success for hopefully the next, I'm not saying hopefully the next pandemic, for the next pandemic. And I'm not looking to fall on the sword for COVID-19. Now, if we get another variant that otherwise ramps up, and if we need to push out more vaccine and everything, at least these pathways are in place, okay, for us to be able to ramp up. So my whole focus here was trying to be able to get past the no-no-nos to yes, you can in these certain circumstances, so that way that yes, you can in these circumstances can expand into yes, we need to, okay, going forward. Like I said, I'm backing into the vaccine hesitancy question because I didn't address it at all. I basically went around it. I said, I'm not going to fight that fight. If you don't want the vaccine at this point, despite having a vaccine clinic that does 5,000 vaccines a day, multiple places where you can get it from your primary care, and you still haven't gotten it, I'm not sure I'm going to be able to convince you as an emergency medicine provider why you're here for your broken leg. Okay, so I just basically skirted around that whole issue of vaccine hesitancy and went for the low-hanging fruit, which are the people that are willing to otherwise get vaccinated. So with that, I'm going to back into vaccine hesitancy with Dr. Waxman.
Yeah, that was great. That was great.
Sir.
Sorry, I was just
Yeah.
wondering did you just do it at Greenville or did you do it in
So good question. Yeah. So any kind of procedure like this that goes out through our departments has to be something that can then be pushed out to all the emergency departments, which is why we also had a delay. So yes, it went to all of our upstate sort of emergency departments. And so in October we did like 5 at our Oconee, which is way up in the one, like 3 in Hillcrest, 4, and so there was another 15 or so, say in October, that was done at our other ancillary sites. It followed the same mirror, so like 45 for our main site, that's our busiest site, and then proportionally the number of vaccines that were done at the other sites were down. Now, I'm still excited about this because there was very little advertisement that I pushed out to my physicians and stuff like that, because I'm already hitting them with emails about alternative to opiates and HIV and hepatitis C screening. So adding this on there was not that crucial, but the fact that the capacity was there for our physicians that were really passionate about it, I was able to help support them and support the hospital's mission to have some capacity that then we could ramp up. So that was my whole goal with everything in our clinical area.
It's good. Ben, Kieran, Dan, Greg, Alex, I mean, this is like true friendship here.
8 in the morning?
Yeah, I mean, like, so thanks for giving us the opportunity here to have a thing. I actually learned a lot from listening to you guys. I'm glad we did this. I learned like 1,000 thoughts are running through my mind, so if it's just me who, anyway, so I'll go for a little bit.
Good for you.
Yeah.
We're happy.
So it might be helpful to consider unvaccinated people in the United States in the context of this model recently created by Dubé et al. These authors considered unvaccinated people as falling into one of these 5 categories: those without access, those who cannot afford vaccination, those who are not aware of the need, those who do not accept vaccines, and those who are not activated to get this vaccine. We've seen this before, a lot of health-related change, a lot of emergency department relevance here. A simplistic version of this in the vaccine field might be to consider or under-vaccinated ED patients as either those who have barriers to vaccination or those who have hesitancy to vaccination. And they can kind of, so, you know, you like didn't know you were doing this at the time, or maybe you did, but it was like the perfect kind of way to go about attacking that. There were a few studies looking into ED vaccination before COVID. I think Dan actually did one a long, long time ago. With the most relevant on this particular topic probably being this 2006 study by Rimple et al., an emergency department-based vaccination program overcoming barriers for adults at high risk for vaccine-preventable diseases. And in this study, the authors found barriers to vaccination, including lack of insurance, younger age, lack of perceived need for vaccination. Importantly, they commented, we were able to overcome all of these except for perceived need, and that's kind of what we're facing right now. Depending on where you live, it's a big challenge. Like in Albany, we have kind of lower under vaccination rates. Probably in South Carolina, they're a bit higher. I assume, maybe that's assuming too much. So there's been a lot of study on the important topic of COVID vaccine inequities. Community-based surveys typically find between 25 and 45% of Americans are vaccine hesitant. And there's various demographic and clinical reasons associated with vaccine hesitancy. These include all the usual suspects. I'll let you read them there: Black or African American, female, uninsured, et cetera, et cetera. I'll let you read this here, and we'll skip to the next one here. There's 2 important studies. So there's like 3 authors of our study, maybe 4 here, so these were 2 studies that kind of were published before us. These were well-done studies, had a lot of patients that they recruited. And the first was by Rodriguez et al., who found an association with vaccine hesitancy in the emergency department. The association was with lack of regular source of medical care, younger age, female sex, black race, Latinx ethnicity. Fernandez-Penny et al. Found a vaccine hesitancy of 31% or 32%, and they found an association with black race, younger age, lack of trust in government resources. So, well, there's like a few people who wrote this study with me. So this is our study real quick. We did after random selection, we enrolled 610 patients across 5 sites. 58% were vaccine intent, and 42% we categorized as vaccine hesitant. And we randomized each study participant to one of 4 different hypothetical vignette messages: simple opt-in message, a recommendation by the hospital, a strong community-oriented message, and an acknowledgement of vaccine hesitancy. So just like we were talking about, among vaccine intent ED patients, we can see that a hypothetical receptivity to vaccine message is fairly high, no matter how one engages the patient. These are folks, so in the emergency department setting, I would say these are folks who really want to get vaccinated, but either don't have the time or energy or kind of motivation or the wherewithal to get their vaccination. These would be the W's, right? And so let's go get them. And they're there, actually. There are people who I wanted to get vaccinated, I just kind of lost my card and I didn't want to go, or I'm too busy. If you can give me one now, that'd be great. Or perhaps some homeless individuals who might not have the wherewithal. Not surprisingly, hypothetical receptivity was overall lower among vaccine-hesitant ED patients. Importantly, however, we found that receptivity was highest with a simple opt-in message, with a 40% receptivity when patients were asked in this way. So I think that's just it. You don't really attack them or get into it with them and argue. That's the last thing in the world you want to do. Would you like a vaccination today? Is probably the best. There are some other techniques that we might use, such as motivational interviewing. Phil was telling me, Dr. Michela was telling me today about some person who's developed some game on an iPhone that you can play the game and kind of explore maybe some myths about vaccine hesitancy. I'm kind of curious to see how that works. My guess is it won't work great just because of all of the stuff. But yeah, but maybe in that context, maybe that context will help break down barriers. That'd be great. I definitely wouldn't argue with patients. That's once you start arguing with a patient, you're just absolutely toast. You use a routine, presumptive approach, and that might be best when engaging patients. And future work might look into strategies such as motivational interviewing and stuff like that, this game theory, et cetera. Okay, I can't thank you guys enough. We have 5 or 10 minutes left. I don't know if any of you guys thought of anything. Alex, well, Greg and Alex, it's good to have you guys in the audience. The truth is, you're good minds, and maybe bring something to the show here.
I doubt it, but my biggest curiosity is what happens when this becomes. I think we talked about this the other night. Annually, there's my guess is that there's a vaccine coming. Right? That's just a guess. We do flu shot stuff at the hospital all the time. It doesn't seem to be a big problem, right? I guess how do you get from where we are with this extraordinarily stigmatized COVID vaccine to being oh yeah, it's just a stupid vaccine I have to get annually in order to, maybe it'll prevent me from getting it, maybe it won't, probably prevents me from dying. How do you get there?
Thanks.
Where we are now with all of this?
Dan, did you want to comment on that? You look like no.
I don't have a great answer for that. I anticipate, like you do, that there'll be vaccines coming out that'll be more appropriate to strains that should be more frequent in terms of ready. I think for us, it's just the first step of what they did in their studies. Is we have to bring up the issue. And, I really like the screening way that you did it with the nursing. That I don't think we have it as a question where we screen.
And part of that was again, as our health departments, and even the VaxMart, trying to upload that information because they mandated, since we were taking basically the state supplies and through the hospital to do all the community work that our public health department wasn't doing. I hope they're not listening to this because they still pay me to do HIV screening, so don't cut off my funding. But the issue was that they just don't have the manpower, right? And so they came to us to otherwise use that. And so we were having to upload into the databases and stuff, and that didn't really link up with Epic, and we weren't otherwise double dipping as far as logging that they had the vaccine both in Epic and on the national database. And then when we tried to link it in, it sometimes worked and sometimes didn't. So we had a really hard time knowing actually who was vaccinated, right? Because we weren't getting everybody's vaccine card. So again, some of that question was already a little bit there just for self-preservation, just to try to make sure that the fidelity of the link of those databases was correct and that we weren't missing people that got vaccinated in different places. And so I just was able to add on to that and say, like, hey, since you're already asking, why don't we add this on? You know, and so it was very Machiavellian in the way to kind of get at it. So that's the other part about it, is just really trying to be nimble.
Convince our nurses to do anything additional. Like, this really had to come on the clinician side because our nurses have no interest in an additional triage question.
Yes,
That would
the-
have actually been a harder
Or
sell
even-
than what we did.
And that goes along with it too, is in the same sense is that the hospitals love, check boxes where they can track and do everything because they get bonuses for saying, oh, we asked if they are safe at home and da-da-da-da. And so triage has become this bloated process, especially for the emergency department where it's, like 25, 30 minutes. They're like, are you kidding me? This is not going to work, especially for the emergency department. So I hear exactly what you're saying. But the mandate is that we need to know whether they're COVID vaccinated. And so then I was able to try to work on that. So that's the other thing. And now I'm trying to do take a penny, leave a penny to pull that out to ask for other questions. But
I think to your point though, I think this group is sort of the choir, and the problem is we're still a minority, even giving flu shots.
Yeah.
That's a small group of places, I think, percentage.
yeah, very much so, very much so. And
Unlike tetanus.
no, I get that. But at the same token, as long as you have capacity, right? So then the ability becomes capacity, then it becomes old hat, then you can just ramp it up, right? And depends on what sword you're going to fall on to try to ramp it up on.
We were talking, how would you give the emergency department in responding to the vaccination or to the COVID-19? We said we'd give ourselves an F, in emergency medicine. We just did not. So the question is, however, then I asked Rich, how would you give the emergency department a grade for HIV screening over the last decade or so? And Rich said, I don't know, maybe a B minus. So for HIV screening, we helped a little bit. What do you think?
That seems high.
But the other.
We helped a little bit in Albany, in
Yeah, but-
cities in Boston.
But my argument isn't that the screening, right? Because it's not that we're trying to use the ED to find COVID patients. The real argument there is what's our efficacy on getting people on PrEP, right? Because a vaccine is something there to prevent somebody from getting infected, right? So what's the ED's response to rolling out PrEP, right? And I would say we're double F minus, right? We don't do that at all.
I would just, to circle back to Alex's, 15 years ago, no one did HIV screening in the emergency room. Now you come in, you have someone who's got an opportunistic infection maybe and a low white count, and you can order it, you just click on the button, and you order it, and everyone thinks about it, and there's no big deal. I have a feeling that vaccination is gonna be that way, but we need to get there. It took us a decade and a half to get there.
I think the other side of that is the hospitals make money on it when you give somebody a vaccination as part of preventative health. So if you can bill for it, the hospital's going to want you to do it.
It seems like there's two other really big issues that we should maybe dovetail into this discussion. As time goes on. One is social determinants of health is huge for
Yeah.
emergency medicine.
Yeah.
And the second is they're looking for ways to define our role better with this whole idea about too many physicians and things like that. And this is the scope of practice. This whole idea about public health is really big. And we need to own that. So those two things might be really good opportunities for
Yeah.
this group.
I think we've reached our time. I can't thank you guys enough for giving this opportunity for me to listen to Dr. Kirk